Welcome to Mueller's Anatomy Bedtime Talk. My name is Mueller Pierre-Louis, and I will be your host this evening. Stick with me as we tackle some of the hardest and complex concepts in anatomy and learn some fun and easy ways to recall your anatomy so that you're a master of the human body in no time. On today's episode of Anatomy Bedtime Talk, we will be covering the brachial plexus. Brachial plexus is the group of nerves that give innervations to the muscles that are responsible for the movements of the hands and the arms. In order to understand the brachial plexus, we must understand its composition. Brachial plexus is composed of spinal nerve roots that form trunks, and trunks that give rise to divisions, and divisions that become cords, and cords that become nerves or branches, depending on how you name it. So once again, brachial plexus first starts off with spinal nerve roots that become trunks, and those trunks give off divisions, and those divisions become cords, and those cords become nerves or branches. The best way to learn brachial plexus is to draw it. But because we are snuggled in to our blanket right now, make this a task that you do the next time you get to a board with a marker, is that you draw out this brachial plexus. Try to draw from right to left, because that's the most conventional order, starting with your nerve roots on the right side of the board. Brachial plexus is composed of the nerve roots C5, C6, C7, C8, and T1. The nerves from C5 and C6 fuse to form the upper trunk. The nerve from C7 forms the middle trunk, and the nerves from C8 and T1 fuse to form the lower trunk. The anterior division of the upper and middle trunks form the lateral cord, and the anterior division of the lower trunk forms the medial cord. The posterior division of the upper, middle, and lower trunk form the posterior cord. The lateral cord will give off a branch, as well as the medial cord, and the branch of the lateral and the medial cord will become the median nerve. The remainder of the lateral cord will become the musculocutaneous nerve, and the remainder of the medial cord will become the ulnar nerve. The posterior cord continues on to become the radial nerve. Now that our brachial plexus foundation is in order, it is time to add the remainder of the nerves. Coming directly off of spinal nerve root C5, we have dorsal scapular nerve. Coming off of nerve roots C5, C6, and C7, we have long thoracic nerve. When we make our way over to the trunks, coming off of the upper trunk, we have suprascapular nerve and nerve to subclavius. Luckily for us, there are no nerves that come off of any divisions, but coming off of the lateral cord, we have the lateral pectoral nerve, and the lateral cutaneous nerve of the forearm is actually the continuation of the musculocutaneous nerve once it enters the forearm. Coming off of the medial cord, we have the medial pectoral nerve, the medial cutaneous nerve of the arm, and the medial cutaneous nerve of the forearm. Off of the posterior cord, we have the axillary nerve. We have the upper subscapular nerve, the lower subscapular nerve, and thoracodorsal nerve. Now that we know the nerves that come off of the brachial plexus, this is a great opportunity to practice if we know which nerve roots contribute to which terminal nerves. Let's use musculocutaneous as an example. Musculocutaneous nerve arises from the lateral cord. We know that the lateral cord arises from the anterior divisions of the upper and the middle trunks. The upper trunk is composed of C5 and C6 nerve roots, and the middle trunk is composed of C7 nerve roots. Therefore, the musculocutaneous nerve comprises of the nerve roots C5, C6, and C7. Using that pattern, we can conclude that anything coming off of the upper trunk will have the nerve roots C5 and C6. Anything coming off of the medial cord will have nerve roots C8 and T1. And then the median nerve has all C5 to T1, same thing as the radial nerve. We do have some exceptions though. such as the axillary nerve having only C5 and C6, even though it comes off of the posterior cord, which pretty much takes the posterior division of all three trunks. However, we do have a mnemonic that helps us to remember some of the difficult nerves on brachial plexus. If you lift your hand and you number C5 as your thumb and your pinky as T1, and each of the fingers on your hand representing the nerve roots in brachial plexus, then when you stick up your thumb, your index finger, and your middle finger, that would be C5, C6, C7, correct? So the mnemonic goes 3 musketeers, where you hold up 3 fingers for C5, 6, and 7, and that represents muscular cutaneous nerve. Assassin, where you point out like a gun using your thumb and your index finger, and that represents C5 and C6, and the word assassin with the A represents axillary nerve. 5 mice, you put all 5 fingers for C5 to T1. 5 rats, right? Because mice was median nerve, and 5 rats is radial nerve, which also represents C5 to T1. And then you use your 4th finger, your ring finger, and your pinky finger to say 2 unicorns, right? Which represents C8 and T1, which represents the ulnar nerve. It goes 3 musketeers, assassin, 5 mice, 5 rats, and 2 unicorns. And if you do the hand and the finger motions properly, it kind of helps you remember the weird nerves on brachial plexus that either encompasses all the nerve roots, or like axillary nerve, where it's not as obvious that it's only C5 and C6. And let's be honest, ladies and gentlemen, they're never going to test you on nerve to subclavius on an exam. The nerves that are heavily tested are the nerves that are encompassed in that mnemonic, because those are the nerves that innervate the muscles that, when we see pathology, is normally the nerves that are involved, right? The musculocutaneous nerve, the axillary nerve, the median nerve, the radial nerve, the ulnar nerve. Those are the high-yield nerves, so that's why that mnemonic actually works perfectly. But now let's get to the part that we've all been waiting for. Let's get to the clinical correlates and to the pathology. Brachial plexus passes in between the first rib and the clavicle under the pectoralis minor muscles attachment to the coracoid process. In hyperabduction syndrome, keeping your arm in a prolonged abducted position, such as sleeping or overhead painting, leads to compression of the actual brachial plexus and some of the vasculature as they pass under that coracoid process and pectoralis minor. So as a result, what you have is numbness and tingling in the extremity. Another common cause of compression to the brachial plexus is if you have an aneurysm in the first part of the axillary artery. This also causes pain and tingling. If you have an axillary lymph node dissection, which they normally do if they're checking for if cancer spread to the lymph nodes, as an example in breast cancer, you run the risk of damaging the long thoracic nerve and the thoracodorsal nerve just based off of their anatomical location. Damage to the upper trunk, which comprises of C5 and C6, leads to Herb Duchenne palsy, also known as waiter's tip deformity, where the upper limb is adducted, medially rotated arm, and extended elbow. This normally happens during childbirth with shoulder dystocia, where in order for them to deliver the baby, they pull on the neck, which hyperextends the neck, pulling up on that upper trunk, leading to this deformity. A lesion of the lower trunk, C8 and T1, leads to clumsy paralysis, which presents as claw hand, and you have a potential for Horner syndrome. Horner syndrome, as we know, presents with meiosis, ptosis, and anhydrosis. If you have a mid-shaft fracture of your humerus, you will have a radial nerve palsy. The radial nerve travels close to the bone, the radial groove on the humerus. And having a radial nerve palsy will present with wrist drop and loss of sensation to the dorsum of the hand. The radial nerve is responsible for most, if not all, of your extensor muscles in your arm and your hands. A surgical neck fracture of the humerus will give damage to your axillary nerve. This is from landing on your shoulder during a fall. Loss of innervation to your deltoid muscle, which you use for abduction, and you have depression under the acromion. Carpal tunnel syndrome is damage to the median nerve. You have swelling of the flexor retinaculum as a cause, and it presents with apand, and you have pain during wrist flexion. That's worse at night. Apand is when they can't move their thumb away from the other four fingers, and it presents kind of like an ape's hand. And then last but not least, we have wing scapula. Wing scapula is damage to the long thoracic nerve, the C5, C6, C7, wings to heaven. And this normally is when you have either mastectomy during surgery or you have a trauma to the lateral chest. Remember that we talked about the axillary node dissection, lymph node dissection, possibly damaging the long thoracic nerve. This is what it can present with, and it is a paralysis of the serratus anterior muscle. So know your pathologies and your lesions very well. If you have an upper trunk lesion, C5, C6 is Erb-Duchesne's palsy. If you have a Klumpke palsy, is a lower trunk, C8, T1, and that will present with the claw hand and possibly Horner syndrome. If you have radial nerve palsy, you know it was from a mid-shaft fracture, and that will present with wrist drop. If you have carpal tunnel syndrome, that's a median nerve damage, and that will be pain during wrist flexion, possibly apand. If you have wing scapula, you know that's damage to the long thoracic nerve, right? So look at possible trauma history or surgery history or lymph node dissection. And then surgical neck fracture of the humerus, you should be thinking axillary nerve. And that's falling on their shoulder and unable to abduct their shoulder, or they have a loss of sensation over the deltoid muscle. Last but not least, damage to a spinal root will cause a dermatomal pattern. However, damage to a peripheral nerve will cause a cutaneous sensation pattern. So as an example, we know that reactivation of the chickenpox virus, herpes zoster, it affects sensory ganglia, which is right at the nerve root. So the virus spreads in a dermatomal distribution. And this ends our Anatomy Bedtime Talk episode of Brachial Plexus. Once again, my name is Mueller. I'm your host, and thank you for joining me as we tackle the concepts of anatomy so that we all can be masters of the human body one day. Thank you, and see you next time.